Good morning. Thank you for inviting me to give this keynote presentation on the findings and recommendations from the HSIB investigation into delayed recognition of aortic dissection. The investigation was published in January 2020 and is available on our website hsib.org.uk. I will focus on our investigation in delayed aortic dissection, but you might also be interested to read our report into the transfer of critically ill adults, which also led on from this case of aortic dissection. So this morning I'd like to tell you a little bit more about me and to introduce the team who produced this investigation. Then I want to tell you Richard's story before describing our findings and recommendations. And finally, I'll update you on the response to our recommendations from the organisations who received them. First, a little about me. Until last month I was the Director of Investigations for HSIB here at our head office in County Technology Park in Farnborough, where I spent 2 fascinating years developing HSIB's investigation process and shaping the future of the HSIB described in the NHS Reform Bill that's currently going through Parliament. My secondment has now ended and I've returned to my full-time role as an intensive care consultant here in Brighton, and only last week I found myself caring for a patient who had had successful surgery for an aortic dissection, so this is a subject which interests me on many levels. Now I'd like to introduce you to the team who successfully completed this investigation. Richard and his partner. HSIB was established in 2017 as an independent body to undertake safety investigations in NHS-funded care in England. We work cooperatively on patient safety with other NHS bodies, but are functionally separate and act independently. This was our first investigation. HSIB's purpose is to identify the safety risks, follow the evidence and develop effective safety recommendations. We do not apportion blame or liability, and you will see from this investigation that we do not focus on individual actions, but rather on system-level change that supports staff to make the right decisions. More recently, we've taken on an educational role to professionalise the role of a patient safety investigator. As I've described, HSIB's investigators and analysts have diverse backgrounds. One thing they share is a detailed understanding of human factors and how the study of the interaction between humans and their environment in the workplace can influence performance. Our investigations are multidisciplinary and inclusive, and critically important is the role of patients and family in our investigations, and also that of the staff involved in the incidents. We operate a no-blame culture, and we offer staff the opportunity to tell us their experience of patient safety incidents in a safe space, and will not divulge their evidence to others without an order of the High Court. We aim to be transparent and collaborative. While we're not a regulator, we seek to work with other NHS bodies to develop recommendations that will bring about the change that we think is required. Just to highlight, we investigate in 2 programmes. The aortic dissection investigation was carried out under the 2016 directions, but we also investigate up to 1,000 incidents in maternity care per year. Our intelligence unit received over 400 referrals since HSIB came into existence, and we've progressed 68 investigations to full national investigations. The criteria used to decide which referrals to investigate are firstly on the outcome impact, that is the impact to patients and their relatives of the patient safety risk. Secondly, to understand whether this is a wider systemic risk or whether it's a risk that's limited to an individual organisation. And finally, whether there's any learning potential from the investigation that we would carry out, or whether there is sufficient activity going on in that around that particular safety risk already. To date, we have carried out 51 investigations and made 143 safety recommendations to 40 different organisations. The HSIB investigation process is divided into 2 main phases. The scoping phase is where we carry out a detailed investigation of the reference case. This is carried out by taking interviews from patients, families, and from the staff involved in an incident. We also carry out observations in the site where the incident occurred, and sometimes we make comparisons with other organisations. We enlist the help of subject matter advisors and experts by lived experience, so we understand the subject at hand as fully as we can. And once we've done that scoping phase, we try to understand what are the national safety risks that might be emerging from the reference case. And the national phase of the investigation allows us to have a deeper exploration of national systems relevant to the safety risk. For example, national guidance, NHS commissioning, education, and things like regulation. Increasingly, we try to use a systematic approach to our investigations, and currently our main approach is using the Systems Engineering Initiative for Patient Safety, or SEIPS. And this is a human factors based investigation tool which divides the healthcare system into three main buckets. So there's the work system, the process which is being carried out in that work system, leading to an outcome for patients, the employee, the organisation. If we look a little bit more at the work system, so the work system can be divided into the external environment in which the work is occurring, the organisation the work is occurring in, the environment, so whether it's hot, cold, whether the emergency department is busy or quiet, the people involved, so doctors, nurses, allied health professionals, the patient, the family members, any equipment that might be used during the incident, and the task that was being carried out, and of course, importantly, the interactions between all of these things. So by investigating and putting evidence into each of these buckets, we can build up a picture of the incident and help us to analyse what the underlying causes were. So moving on to Richard's story. Richard was a fit man in his 50s. He developed severe sudden onset chest pain while lifting weights in the gym. His pain improved, but he still felt unwell. He returned home and called NHS 111, who advised Richard to take 300 milligrams of aspirin and dispatch an ambulance because they were concerned that this may have indicated that he was having a heart attack. The paramedics arrived and assessed him and thought that muscular pain was most likely, but were still concerned about the possibility of a heart attack, and so transferred him to the emergency department. The emergency department was busy, and so Richard had to wait for about 30 minutes to be seen by a triage nurse, even though he was suspected that there was a concern that he may have had a heart attack. The triage nurse used the Manchester triage system and assigned him a category 2, which this is an algorithm used to assign priority of treatment, and a category 2 would indicate that Richard should have been seen within 10 minutes. Blood tests as an ECG were carried out, and assessments were made by advanced care practitioners and junior doctors over the subsequent 2 hours. His case was discussed with an emergency department consultant, but no diagnosis was reached. And although Richard looked reasonably well, the staff were concerned enough to recommend admission to hospital. And at this point, the medical registrar who received the referral had recently seen a case of aortic dissection and became more concerned. She requested a blood pressure measurement in both of Richard's arms, and when there was a discrepancy, she requested a CT angiogram. When this was reported an hour later, it confirmed the presence of a type A aortic dissection. And after discussion with the cardiothoracic unit, Richards was transferred, but suffered a cardiac arrest 12 minutes into the journey, and sadly died despite resuscitation attempts. The CT aortogram was performed 4 hours after arrival, and Richard's transfer was commenced 5.5 hours after he arrived at hospital. So HSIB carried out an investigation into Richard's case using the process I described earlier. So we interviewed Richard's partner, we interviewed the staff in the emergency department, and we interviewed the paramedics involved in Richard's case. And we discovered the following findings: that acute aortic dissection is an uncommon cause of chest pain with a high mortality. We were unable to discover much national data about what happens to patients with acute aortic dissection before they reach a specialist centre, including the pre-hospital phase. And of course, as I think most people in this room know, that severe chest and back pain, which sometimes improves, is the most frequent symptom of acute aortic dissection. I think we all realise that early recognition and treatment of acute aortic dissection improves survival, and that a CT aortogram is the most widely available investigation of choice. In terms of early recognition, we know from research that delayed recognition of acute aortic dissection is common, and so Richard's case was not unusual. Our investigation also found that most staff do not have personal experience of acute aortic dissection, and most have only come across it in their education and learning, and this may have been some time before they see the first case of aortic dissection in real life. It's also true that chest pain is a very common presenting symptom, and it has many causes, some of which are life-threatening, but many are much more benign. So our investigation focused on decision making and how staff arrive at the decisions required to make a diagnosis of acute aortic dissection. So we focused on decision making, and we found that the ED is a decision making system. Its purpose is to allow staff to make decisions to further the diagnosis and treatment of patients. The effectiveness of the ED as a decision-making system will depend on a number of factors. For example, how busy it is, staffing levels, seniority and experience of staff, whether they've had any rest, the availability of equipment, etc. We also know from psychological literature that people make decisions using mental shortcuts called heuristics. Often these are helpful and allow us to make quick decisions, but are also prone to biases. And we can use heuristics to ensure that we design systems that enhance the use of those heuristics to generate more reliable decisions. One example is the availability heuristic. So simplistically, it's easier to diagnose acute aortic dissection if it's at the front of your mind. And the example in our case is the medical registrar who made the diagnosis had seen a case of acute aortic dissection recently, and so was able to use the availability heuristic to make the right diagnosis. Staff might become aware of a particular diagnosis or set of symptoms through individual experience, such as our medical registrar, through individual training, and simulation training is particularly effective at this, or through organisational rules, guidance, and awareness campaigns. So I think everyone in this room is aware of these publicity campaigns. So we have the safety alert from the Royal College of Emergency Medicine from 2016, and more recently the Think Aorta campaign. Now these have been very successful in raising the profile of aortic disease to the emergency department community, but are only as good as the publicity campaign behind them. Just putting a poster on the wall of the emergency department coffee room is unlikely to be terribly successful, so ongoing publicity in relation to these campaigns will be required to continue the success. We also looked at the triage systems, because of course if we raise the profile of aortic disease in the triage systems that are used in emergency departments, we will again bring the possibility of the diagnosis to the fore of those people required to make a decision. So we examined the discriminators for acute chest pain in the Manchester triage system, and these are the discriminators used, and you can see that they're pretty biased towards cardiac chest pain, or indeed pulmonary embolism, but there's very little in here, if anything, that would discriminate out aortic disease. And indeed other ED triage systems do not make specific mention of aortic pain. And so we made the following safety recommendation. We recommended that the Manchester Triage International Reference Group should consider the addition of aortic pain to the Manchester Triage system, and to raise the awareness of acute aortic dissection as a potential cause. And we also made a safety observation that it would be beneficial if other providers of emergency department triage systems were also to consider the addition of aortic pain as a discriminator. We're also very pleased to say that during the course of our investigation, NHS Digital amended the content of the NHS Pathways algorithm, which is used by NHS 111 for the telephone triage of patients, to help improve the recognition of chest pain likely to be associated with acute aortic dissection. And this is really interesting part of our investigations where bodies just take on our recommendations before we've completed our report, and in this situation we then issue a safety action, and so we're very pleased with NHS Digital's response to our investigation. Another part of our findings was that there was a need to improve chest pain diagnosis. We found that there's no national strategy for the detection and management of acute aortic disease or a systematic approach to non-cardiac chest pain. There are some individual organisations that do have very good systems, but these are not widespread across the NHS. There's also some perceived limitations on CT capacity which may deter staff from requesting the definitive test. And we feel it's important to raise staff confidence to request the appropriate test. There are some aortic dissection detection risk scores which may be useful, but they've not yet been validated. And training, and particularly simulation, may increase the reliability of people arriving at a diagnosis. And so we made the following recommendation to the Royal College of Emergency Medicine and the Royal College of Radiologists, that they should develop, deploy and evaluate a national evidence-based process for detecting and managing patients with acute aortic dissection presenting to the emergency department. And ideally this should form part of a wider strategy for managing non-cardiac chest pain in the emergency department. And because of course people don't present to the emergency department with aortic dissection, they present with chest pain. So it's important that any strategy is designed to allow staff to discriminate between the different causes of chest pain. I'd now like to just update you on the response to our recommendations. So first of all, the Manchester triage system. They replied to us that, as recommended, they considered the addition of aortic pain as a discriminator in the Manchester triage system, and we're very pleased that they've added this not only to their chest pain chart but also to the charts of back pain, abdominal pain and collapse. So we think that's a really helpful response to our recommendation, and we hope that that's going to impact on the availability of the diagnosis to the staff who are making the diagnosis. The Royal College of Emergency Medicine and the Royal College of Radiologists have also been extremely helpful. And they've described that they're developing a working group to carry out the HSIB recommendation, and this working group is due to publish its guidance this year. They also comment, however, that this, together with the right consultant capacity within emergency departments, will help the multidisciplinary team to quickly recognise the signs of acute aortic dissection and enables the swift life-saving action to be taken. So as I mentioned earlier, the importance of the ED as a decision-making system, having the right staff available at the right time to make the decision. So in summary, this was HSIB's first national investigation. It demonstrated the complexity of modern healthcare and the challenges of incident investigation in this arena. But I think despite the challenges, by using a system-based approach, we generated some impactful recommendations that our NHS partners are now carrying out. It's quite clear that deaths from aortic dissection can be reduced by the improvement of healthcare systems to support staff in the early recognition of the condition, its timely diagnosis and appropriate treatment. So thank you for listening. I hope that's been of interest to you, and if there are any questions, I'll take them now. Thank you very much.